Hey, so I'm Dr. Anthony Kaveh, Stanford and Harvard trained anesthesiologist and integrative medicine specialist, here live and unscripted in a real operating room to share with you patients that I have accidentally triggered when they're under anesthesia on that table. And I'm holding a breathing tube here because this is where the questions that I asked ended up being related to the breathing tube and what happened to that patient who got triggered by that question. So I'm calling a patient the night before they come into this room before surgery. I have to ask about their height and weight because that determines what kind of breathing tube I'm going to use. It determines how much of the medication they're going to get. Very rational questions, non-judgmental. I didn't know that this patient was going to have an uncertainty, doubts, fears around revealing this number, and it didn't go over so well. Linda, Heidi, good to see you. Steph and everyone else coming on, so good to see you. Well, the next day when they came to surgery, of course, I wasn't aware of what had happened the night before because they just answered my question and they hung up after we said goodbye. So the next day they come in, we asked the same questions, then they come into this room. And I had a sense they were a little bit agitated by something. It wasn't until they came onto this operating room table and I gave them a little bit of relaxing medication, kind of similar to the white stuff propofol. Anesthesia really greases the wheel for triggers to come out. And I asked them what I ask all patients before they fall asleep: what are you going to eat when you wake up? Well, that did not go over very well. It didn't come from a place that was meant to be in any way shaming. It's because the more we're ready to eat when we wake up, the less nauseous we're going to be when we wake up. It's one of my favorite, it's almost like clinical hypnosis, if you will. I'm not hypnotizing per se, but I'm using the suggestible state of anesthesia to minimize the risks of side effects, nausea being a big one. By the way, Randall, thank you for the kind comments. I appreciate it. Juanita, Sam as well, thank you. So when this patient was on the table here, this is the last time and place I want a patient to be triggered. Because if you fall asleep triggered with the frustrations, angers, literally, you're connected to the life support monitors here behind me. And it all shows. So this patient's heart rate went up over 100 beats per minute. Their blood pressure skyrocketed. They got flushed in the face. They were pissed. And I did not mean for that to happen at all. So they took my questions about height and weight and what they're going to eat after surgery the wrong way. So I felt very bad, of course. It was not my intention at all. This particular demographic was at high risk of having nausea and vomiting after surgery was over. And that's why I specifically gave all the medications. But as you may know, medications alone don't always cut it in patients that are at high risk for having nausea and vomiting after surgery. So, hey, Pickles, good to see you. Now, what happened to this patient, I'm going to tell you about, and also more broadly and importantly, what are triggers and how does anesthesia bring these triggers out in ways that can be helpful or hurtful? It's fascinating topic. So if you appreciate me coming here after a long day in the operating room, I would appreciate if you hit that like button and share what you learned with others so that you are more empowered to advocate for your own health and inspire others to do so as well. As you know, no ads, no product placement on my part, knowledge for you. I want you to not fall into the same trap that this poor patient did on a table similar to this one not too long ago. So what happened to this patient? Well, you have to understand that anesthesia disinhibits the frontal lobes of our brain, depending on whether it's propofol, ketamine to an extent, whether it's one of the anesthesia gases that comes out of here. There are lots of effects, of course, of anesthesia on the brain. And it exemplifies the placebo and nocebo effects. Have you heard of the nocebo effect? Because this is powerful, and it has so much to do with triggers. So I'm going to put the camera here so it's not moving around so much. Was the patient anorexic, Lowy Springs? No, it was the opposite, the other way around. So, hey, let's talk about it. I'm wishing you the best for your MRI. I hope that there's nothing wrong with your shoulder. So The placebo effect is when an external stimulus causes a physiologic change in your body for what we'd like to believe to be in a positive direction. So for example, when antidepressants are given and placebos are given, many placebos improve mood as much as the trial drug improves mood. And nocebo is the opposite direction, an external stimulus causing a negative change in our physiology. So before I, for example, put an IV in someone's vein, if I say, oh, this is gonna sting like a bee sting, it's gonna hurt, that's gonna rev up their nervous system. In fact, I see it if I connect them to the monitors, and then that is going to sensitize their nerves, their brain to feeling that pain more. Nocebo, like a noxious placebo. Noxious refers to pain or tissue destruction. Now, triggers are similar because triggers are external effects or external stimuli that cause exuberant responses in your central nervous system. It's rather fascinating how your central nervous system is effectively being hijacked by something outside of your body. It's not a medication. It's not someone touching you. It's mind-blowing, and this happens when you have a little bit of anesthesia on board to a greater extent. So it's more pronounced. That individual was utterly upset. And it showed when they went under anesthesia and how they woke up after anesthesia. So an external stimulus affected their surgical course to an extent, their anesthetic course. And I didn't get a chance to follow up with them for very long. They weren't very happy. And yes, I was apologetic, understanding, trying to be as rational as possible, as compassionate as possible. That's always the case. These are not intentional triggers, not intentionally trying to put someone in such an uncomfortable place before the most vulnerable moments of their lives. And I didn't even mention, this is really humbling too. Imagine you come into this room, there's a whole bunch of strangers you may not know, maybe a representative for a company that's going to supply the hardware that goes in your body, a nurse you haven't met before, a surgical tech and the surgeon, and the person that triggers you is the one who's going to be in charge of your life for the next hour or 2 or 3 hours or 4 hours or 5 hours. It's not a comfortable feeling, and my heart really went out to this patient. That's not the person that you want to feel triggered by, nor is it the person that I want to trigger before such a sensitive moment in their life, unlike any other place in the world. But it shows just how much agency we can have, because triggers are so misunderstood by so many of my patients. Maybe not you, but so many of my patients, they'll even walk into this room and say, oh, I'm triggered by the operating room lights. Oh, doc, I'm triggered by that white medicine you got in the syringe. Oh, doc, I'm so triggered by the smell of this plastic mask. It triggers me. And I totally accept that external things can affect us because we know this always happens. This is not controversial. Unfortunately, what appears to be controversial for my patients, and I practice in the San Francisco Bay Area, there is a lack of accepting responsibility and agency that we can also overcome the effects of external stimuli. I'm not blaming anyone, to be very, very clear. We're acknowledging these are powerful effects on the central nervous system, but we need to also acknowledge, and my patients do this when they're under anesthesia, when they're triggered in a positive way. So I said you can be triggered in a negative way, like the nocebo response, but a positive way. I don't have patients coming in here telling me, well, I'm effectively triggered by being inspired by maybe what I saw a nurse doing in pre-op, graciously helping a patient calm down before surgery. Or I am so inspired by the charity that is sponsoring my surgery going on. How come we don't call those triggers? External stimuli causing a physiologic change in our body, causing the parasympathetic tone to be higher, causing your heart rate on the monitors to lower, your heart rate variability to increase, a release of oxytocin from the pituitary. There's all sorts of effects that happen when we have that type of response, yet There's a lot of focus in my patients that I take care of, unfortunately, on negative triggers, nocebo responses, forgetting that not only are there positive triggers out there, inspiration, motivation, being passionate about what you care to do. I mean, the list goes on, but also that we can control. It's almost like nature versus nurture in some ways, a bigger discussion than we're going to get into now. And I want to thank you for that. But nothing, well, very, very few things in medicine are exclusively a result of nature or exclusively a result of nurture. Far more diseases, health conditions, states of being are a result of a combination, and with enough strength from one direction or the other, that will determine which one wins out. So for example, you can have BRCA. So the BRCA gene mutation is one of the most well-characterized gene mutations for breast cancer and for a couple other cancers. But what people don't talk about, including so many of my patients coming in for mastectomies, and this breaks my heart, it's that when you have the BRCA gene mutation, you have about a 50% chance of developing cancer. That's very high. But what about the other 50%? It's kind of like flipping a coin. So one of the most powerful genes that we know of is a coin flip. It doesn't mean to not be concerned or not to follow up on cancer. That's not the point, but it's to make sure that you recognize there's two parts. If you continue down a path that promotes oncogenesis or promotes cancer growth, like high BMI, high alcohol use in women for breast cancer, you're going to push your body into the direction of the coin flip going in the wrong direction. But the same can be done in the other direction. Same for triggers. When we lose agency, so I'll give you a couple concrete examples because they happen in the operating room. You can have uncertainty. I mean, you're in a brand new room, got these big fancy lights, you got the beeping on the monitors, which I did not connect myself today because I know many of you have told me that it triggers you, and I am totally respectful and I appreciate that being the case, so I'm not going to connect them today. You can go down a path of a cognitive distortion. That's where cognitive distortions, that's the breeding ground, is uncertainties. So all or nothing thinking, fortune telling, mind reading, your brain spins out of control when it's uncertain. This is absolutely not controversial once again. When you are uncertain, your brain will try to fill in the gaps. We call them confabulations, or some people call them BSing. Your brain is trying to come up with data to fill up an incomplete data set. So if I don't know what my interviewer is thinking of me in a job interview, I'm going to do mind reading. If I don't know what's going to happen to me after I wake up from surgery, I'm going to do fortune telling. And if I have catastrophizing personality traits, if I live with chronic pain, I'm more likely to engage in all or nothing thinking. I'm always in pain when I wake up from surgery. I'm never comfortable in the doctor's office. I'm always a drag to myself and others. Right? These are 3 of about 12 very well characterized cognitive distortions that arise when you're uncertain. So the trigger of uncertainty can lead you to a cognitive distortion, or it can lead you to curiosity. This is the one that no one talks about, at least not amongst my patient population, as much as the other types of cognitive distortion related triggers or outcomes from a trigger of uncertainty. So curiosity, well, I'm in this room. I've never been in this room before. Doctor, you're waving around some white juice in front of my eyes. What is that? What is that going to do to my body? Doc, what is this machine what's this green bag? Only maybe for every one patient of mine that asks about what the green bag even is, that they see inflating and deflating as they breathe, and how that works with their body, I have at least 10 patients that come in here engaging in a cognitive distortion, sometimes even before they come into the operating room. So that's one example. What about pain? When patients are confronted with pain, this can be a trigger for emergence delirium when you wake up from surgery. Kicking, screaming, cussing, being unconsolable. We'd like to think that and thank you all, by the way, for the kind comments. I really appreciate that. And I gotta say, Pickles on here actually says we need to take responsibility for our own health. Self-awareness is key to controlling our reactions. Pickles, you nailed it on there. You nailed it that self-awareness is absolutely key. Self-awareness. Thank you. And we're going to come back to that because that's so important. But pain can be a trigger for being completely unconsolable, being like an adult crying like a baby. I'm not making fun of anyone who's had emergence delirium. It's serious. It can have long-term consequences, especially in the elderly. But you know what? We don't know necessarily what causes it every time, but we suspect that it might be related to pain and not having your pain treated. So of course the pain has to be adequately treated when you're waking up from anesthesia. No question about that. But it's more than just that, because a lot of patients wake up with pain and don't have emergence delirium. It's a combination of internal struggle, internal conditions, fears, uncertainties, doubts, coping mechanisms, etc. Once again, it's not blaming, but it's recognizing what are the internal factors that contribute to you waking up completely delirious, with potentially the risks of long-term cognitive deficits, especially in the elderly. I'm not saying that delirium causes that, but there is certainly a correlation that needs to be recognized. I wish we could fix emergence delirium by simply having your family members there with you when you wake up. Unfortunately, it doesn't seem to help. I wish you could just have your mom or your dad or your son or your daughter be there as you're waking up, so as you're kicking and screaming, they can say, "Oh, Johnny, just calm down, you're done with surgery." That's not how it works, unfortunately. It does not appear to be statistically different than those that don't have family members around, which suggests to me, as it does to others, that it's from something likely internal in relation to the anesthesia, in relation to the breathing tube, in relation maybe to being connected to a ventilator. So there's something you can do about that. It's not just self-defeat. Unfortunately, we use this term victimization. I'm not saying that bad things have not happened to people, absolutely. And we need to compassionately and respectfully and with curiosity engage our patients as we need to engage ourselves to learn how the past trauma has affected our body. You know that in the operating room, the body keeps score. Absolutely, when you're on this table with me, your body can sometimes reveal what has come up in its past. But the medications we give, it can expose what's happened to you in the past. These are indelible effects. They are so legit real that they show up on the monitor sometimes, in addition to what you say. But you need to also recognize that, like everything else in medicine, they're not fixed. And if you want proof, for me, perhaps the strongest proof of all is that human beings have the potential to break addictive cycles, even to the most powerful addictive chemicals known to mankind. Nicotine, alcohol, opioids. It's not easy. And I'm not saying people should necessarily try and do this. You need to have the right support. And of course, there's a role for Suboxone, for methadone, for naltrexone, etc. Of course, these are powerful tools. Nicotine gums, etc. There's so many of them. But it's fostering your self-efficacy instead of relying on an external locus of control. It's the power of the internal locus of control that these other factors, ultimately that your doctors are helping cultivate. It's not about us, it's about you. And that's what I want you to take away from all the stuff that I share that happens under anesthesia, because you have more power over your health than you've probably ever been told. Power to control your response to triggers, and power to determine what those triggers do to your body for good or for bad, and to use them for good when possible. Two patients come into the operating room, same stimuli. Some get triggered into panic attacks, some get triggered into wanting to be a doctor. And when I take care of kids, this is one of the most common things that kids will tell me years later. I wanted to be a doctor because of what you did to me in the operating room. Versus the kid that has a meltdown on the table and is scarred for the rest of their life with medical PTSD. I'm not saying it's their fault. Once again, internal and external contributors here. Totally not a blame game. That's not helpful. But recognizing that there is a lot more to triggers than a fixed and movable object that determines your life. It can be the other way around, but we have to take agency. Self-efficacy has to be fostered by you and your loved ones. And if you appreciate that message, please share that with others so that you help inspire others. With that said, thank you so much for your support. I want to answer your questions here. This is another reminder, if you do appreciate me sharing some of the secrets of anesthesia and what some individuals share, do please hit the like button and share with others. So, and Anderson's getting a nicotine patch today. I want everyone here to please send Ann positive vibes. We really hope you nip this smoking addiction in the rear end. Murray, how do you handle patients with body shame issues? Murray, that's what we started this whole conversation about. I should say not the way that I did it, because the way that I did it didn't work. That being said, I don't know the right way because it depends on the setting that you're in. The setting I was in, I don't know how I could have done it better given the very limited time that I had with the patient. I don't want to sound defeatist. I don't know. I would love to know your thoughts perhaps in the comments of what I could have done differently. I'm always open to feedback because I'm infallible like anyone else. I hope that you can be less fallible and I can be less fallible by us interacting like this. But in general, body shame issues, like any type of shame, have to be approached with compassion, respect, curiosity. You have to be curious. You have to try to empathize. And empathize is taking yourself out of me, and trying to do you, and you and me. Great question, Murray. Grace, what time do I go to bed? Depends every day if I'm working late or not, but probably a little bit later today. Mary, thank you for the kind comments. Giannis says, my husband tends to come out swinging. He thinks it's due to loss of control. He had brain cancer as a kid and had surgery at 3 and 7 years old. Well, I'm very happy that they've made it out to where they are. Wow, I'm so happy to hear that, Gianna. It is from losing control. And remember, losing control is another trigger. When you come into the operating room, you're inherently giving up control to your surgeon and your anesthesiologist. Some patients get triggered into a panic attack out of loss of control because the brain craves control. It wants to anchor onto something. It's a boat in a wild sea, right? So it wants to anchor. But instead of being triggered towards a panic and anxiety, some individuals can instead be triggered into motivation for self-efficacy. What does that mean? It means that they're pushed and motivated to learn, how can I take control of my body without resorting to the panic attack route? Because a panic attack is you controlling your body. In the microcosm of your body, you are controlling your heart rate, your blood pressure, your pupil dilation, your sweaty palms. You're controlling something as pathologic as it is. But there's another subset of people that get triggered to be like, wow, let me control my breath. Let me do box breathing or circle breathing or cyclic breathing or 5 in, 5 out or 4-7-8. A subset that force themselves to smile. Because we know that when you smile and you force yourself to smile, you're also affecting your central nervous system. There's people that engage into meditative thought patterns, mantras, etc. There's so many ways you can be triggered by that loss of control to gain self-efficacy instead of falling into panic. I'm not blaming any patients. I'm just as susceptible to these as anyone else. Don't think I have not struggled with anxiety in the past. Please don't ever think that. Don't think I haven't struggled with panic in the past. Even here in the operating room when a patient's about to die, I have felt that, and it was the worst feeling ever. Thank goodness I was a resident at the time, and my attending physician kicked my butt out of the way and took control of the situation. So let me repeat that. I was the resident, my attending, for lack of a better word, took over for me because I was like a deer stuck in headlights. Terrible, terrible feeling. So I'm not immune to this at all. Not at all. Please don't think that. Hey, Bonnie, thank you for the kind comments. Linda, thank you as well. Pamela, likewise. Kimber, what are some signs or symptoms of medical PTSD? Kimber, this is a big discussion. Very good question. It's not so much the triggers that I'm interested in, because everyone's going to have their own triggers. Lights, smells, seeing the sterile walls, seeing a white coat, white coat hypertension is kind of similar in some ways. But it's the difficulty in diagnosing medical PTSD that is, I need to raise more awareness of, because oftentimes when you're in the ICU with delirium, your brain isn't encoding the memories that you'll remember were the source of your PTSD. Just like when you're in the operating room, if you had a little anesthesia awareness, you might not remember what the cause of it was. So I have other videos on that. You should check them out, but it's a very good question. Susie, can I be triggered by your anesthesiologist contribute to going in? Oh, can being triggered by your anesthesiologist contribute to going into shock while you're in the recovery room? Unlikely that one would go into a cardiogenic shock, per se, from a trigger alone. That would be very, very unlikely. Broken heart syndrome is, however, a real phenomena. I don't think an anesthesiologist would contribute. That's often from like death of a loved one or some major life trauma. And my pleasure, Anne. I am rooting for you for this nicotine substance to work. Margaret, thank you. All right, Caliber, do you believe cannabis is addictive? I went most of my life using cannabis, but I'm 2 months clean. It feels good, but it wasn't easy. So Caliber, let's end with this, because this is so powerful. And I got to say, it's really a sore spot for me. This concept that gets thrown around. Remember, I work in Oakland, I work in San Francisco. There's a lot of weed where I work, a lot. And a lot of narrative that, hey, weed is natural, comes from a plant. What else comes from plants, guys? Please tell me what else comes from plants that is far from not addictive. And I'm going to give you a shout out, the first person. What else comes from plants? Gee, name one substance that comes from plants. Bonnie H got it. Opium. The unripe opium seed gave us opium, gave us morphine, gave us codeine. Powerful drugs when used at the right time. Hey, Sherry says barley. You're right. Barley also can contribute to something, but not as much as opioids. But tobacco is also natural. Yeah, hello. Some people are talking about Maine, USA is talking about the original local anesthetic named cocaine. You're absolutely correct. Cocaine came from a plant. There's many addictive plants out there. Weed is a little bit different. Weed can be very powerful. I'm not anti-marijuana, as you know, but when used over time, it affects the brain neuroanatomically, neurochemically in ways that affect your anesthesia requirements. When you smoke weed every day, kind of sound like Snoop Dogg when I say that, I just realized, but anyways, I'm not Snoop Dogg. When you smoke weed every day, there you go again. Sounds just like him. Anyways, you need significantly more anesthesia, up to 200% more propofol. Something is changing in the brain. Something is happening why are patients having worse nausea, worse pain after anesthesia? In some, not all cases, when they use marijuana a lot. There are some changes. Are they addictive per se? Maybe not addiction the way that morphine or that cocaine can be. But there's a change in the body that can develop tolerance to other medications. Dependence. Anyways, hyperemesis from cannabis, like that intractable vomiting, is really, really powerful in a bad way. And that's why seeing enough of those patients has really gotten me concerned for the blanket advertising of marijuana as this panacea. Especially, like 30% THC concentrations, 32%. Hey, there's even an anesthesia strain of weed out there. Unbelievable, unbelievable. Very not safe the way that people think it's safe if used every single day. Hey, Randall also knows about the cannabis, and yeah, a lot of people are talking about the emesis syndrome, hyperemesis. It says too dubbed, too steady. All right. Darian, good to see you on as well. Thank you all for your great comments. And I'm just going to end with Ken Horse saying, been under general twice this year. Prostatectomy, 2 months later, a lobectomy. Then a lobectomy of your lungs. I wonder what lobe that was. Your videos helped me prepare both times. I have to say I was calm and peaceful thanks to your videos. Ken Horse, thank you for sharing that feedback, and please share what you've learned with others so that you can help inspire others to also be calm, to not be triggered in a negative way, but to be triggered in a self-efficacious way. Engaging your curiosity, the innate curiosity that you all have, comes out when you're in the operating room if you've primed your mind for it. I'll just end by saying that you know that I have a ketamine infusion clinic because psychedelic-like experiences or dissociative experiences, like with ketamine, like with any anesthesia, help us reorient things like triggers through the neuroplastic effects that can help patients fundamentally gain inspiration from what used to be triggers in the past. Just goes to show that the inner healing potential is within you, and the sooner in life you realize that you have that power, the more you get to capitalize on that for the rest of your life. So I hope that's what you are appreciating. Until next time, you have more power over your health than you've probably ever been told. Oh, I didn't turn it off. I thought I hit the quit button. Sorry.